I think we'll get started. Obviously, there was a lot to talk about in that break from the fabulous two presentations already this morning. I'd also just note, I had a look outside. You wouldn't know it in here, but the weather, it's like the end of the world out there. The wildest weather for 5 years or something. So I think it's good that we're all safely in here talking about these important topics. I'm Andrew Cuthbertson. Ingrid asked me just to say a couple of words about my background because it's a bit unusual. I proudly call myself a clinical scientist, but it's a bit different than some of the other people we'll hear about today. My background was that I did medicine, history, here in Melbourne, and then an internship and a residency, and I really thought I wanted to be an eye surgeon, which I still think vision research and eye surgery is absolutely wonderful. That's what I thought I wanted to do, really based on mentors that I had at the Royal Melbourne Hospital and other places. And when I was surfing, one of my mentors suggested that I did a PhD, and being easily led, I said, yes, that sounds like a good idea. And so instead of finishing my clinical training, I went off and did a 4-year PhD at the Walter and Eliza Hall Institute, and I never went back to clinical work. So there are decisions we all make, some better informed than others, but I never went back to clinical work. I did 2 postdocs, went to the US for 10 years, ended up working at a wonderful place at that time called Genentech, which was the first biotech company in San Francisco, because they were doing fabulous translational research work. It was the time when they were cloning factor VIII for treating patients with haemophilia A and other things. So just a wonderful, actually, translational research environment. And really what I found, what I thought was fabulous, was translating that basic science research into social and economic benefits in a biotech company. It was just fabulous. And getting that first data from the first clinical trial, I think, to me, is sort of the ultimate. So I lead a very sheltered life. But look, I then came back to CSL. CSL you would have heard of. It's the Australian homegrown biotech company. It's grown a lot. I've been there for 20 years, and I've had the privilege of seeing it grow from being a domestic company just floated on the Australian Stock Exchange 22 years ago to now being the 6th biggest company in Australia. You probably don't realise that, but it's the 6th biggest company on the stock exchange. It employs about 18,000 people. We've got 1,200 scientists in R&D, and we're doing some really ambitious clinical development work, new product development work, biotech products at CSL right now, really doing that translating. We spend about $1 billion a year on research and development. So it's a different path, but in the end I've ended up doing what I found I really loved, which is trying to be a productive clinician-scientist. And I think some of the themes we've heard this morning, and I'm sure you'll hear again, are along the lines of have confidence in the fact that you're really well trained. If you're here, you're really well trained and your skills are desirable, but you need to develop them. In my day, there were very linear paths very linear career paths, and as we've heard and as you know, it's not so much now, but the beauty is you have much more diversity of opportunity, and it's a matter of charting that course and looking at the options that you have. And I think all I'd say is take some risks. You take some risks, try things, work overseas in great places, but then come back. It would be my strong recommendation. And I thought Chris said it very well, that if you try things, by definition, I think you should try things, take some risk. But if you find you don't like it and your gut feeling is this isn't for me, change. try something else. Don't just be a martyr and stick to the first idea. So look, with that, this session now is about who are these clinical scientists that we talk about. If you accept the fact that a lot of the people in this room are excited about the notion of being a clinical scientist, you need some real live role models to hear about. And I think the structure of this session is to introduce you to 3 fabulous, accomplished clinician scientists, but who do really different things and who've had really different life and career experiences. And I'm sure you're going to enjoy it. And my plan is to ask our speakers to speak for, say, 20 minutes and then have time for questions. And we'll do the questions straight after each talk, if that makes sense. So it's a great pleasure first up to ask Professor Kate Drummond to talk to us. Kate is a very distinguished neurosurgeon who combines, she's also a female neurosurgeon, which, in case you don't know, is fabulous and unusual. And she manages to combine the huge responsibility of clinical neurosurgery with research and other leadership roles in Australia and around the world. So a great person to start the session. Please, Kat.
So thank you very much for having me back this year. I was here last year. For those of you who were also here last year, you can either go to sleep or look out for I've put in 4 or 5 new slides and updated some of my results. So you can watch out for the new bits, and I've updated American presidents in my jokes. So hopefully that'll keep you awake. So my topic is, why bother with research when you can spend all day operating? And, well, operating is what surgeons learn to do. That's why we go into surgery. Look at these photos of me operating. I'm smiling in all of them. You can even tell under my mask that my eyes are smiling. And it is such a fulfilling and wonderful skill to learn, and a wonderful thing to be able to do for patients. It's also, of course, the most scary and responsible skill. So why would you do anything else? Well, why indeed? I think from this sort of first question that I've been asked to talk about, 3 questions really arise. Why would surgeons not do research? What do surgeons specifically bring to research? And why would surgeons do research? And I'm going to answer each of those questions. So firstly, why would surgeons not do research? Well, because it's hard and it's time-consuming and it's sometimes soul-destroying. And surgeons don't deal with that necessarily very well. We're often viewed as being a particular personality type. I'm not sure if that stereotype is absolutely true anymore. So I did probably a little bit about like what Andrew said, finished my neurosurgical training and thought, well, I've got to do research, right? I have to go and do research, and I want to be a brain tumour surgeon, so I better go and do some molecular biology or something with all of those 4-letter acronyms, lots of that with rats involved. So I went off to do that. That's me getting my MD, which was a sort of 2-year doctorate for people who already had a medical degree. It was supposed to take 2 years. It took me 11 years to be conferred with that degree. I probably did some good work. There's one of my rats, and below that, of course, is the invading brain tumour model that I managed to put together. But I found this really difficult. For me, doing this kind of research was kind of like trying to wade through half-set concrete. I found it hard, frustrating, and I didn't have that right kind of mind where when one of my experiments didn't work, I'd say to my supervisors, well, why didn't it work? And they'd say, oh, maybe we should have tried 10 millimolar instead of 1 millimolar. And I'd just be like, you didn't think of that before? That's a week of my life you have just wasted. And you can't, it's not like that in surgery. We kind of don't go, oh, well, maybe we'll cut here today and there tomorrow. And so I found it very difficult. And so I would encourage you, for those of you who found research not actually that much fun, that you can actually move on from that. And what it did teach me was exactly the kind of research that I wanted to do, which was collaborative research with the people in the lab with the rats and clinical research with my patients, because patient care was what I was really all about. So, you know, what do surgeons bring to research once you've made the decision that, yes, everyone should do it? Well, we know how to ask really good questions because we have real-world practical view. That's a new slide. Real-world practical view of what the questions are and what will be useful for our patients. So, one of, I think, you know, the pieces of research that I've done that has come home to me only in the last few months of how it has answered a really practical question is this one. So we said, you know, we've got patients who have something that looks like this, which is a low-grade brain tumour, and something that looks like this, which is a high-grade brain tumour. Awful disease, but quite different prognosis and different treatments. And sometimes the histology that we get from the biopsy is not concordant with what we see on the scan. It might come back as higher grade, or it might come back as lower grade than what we expect from the scan. So we looked at that, looking at our massive database and our histopathology results and all of our scans, and we looked at that and worked out that, well, what was more important? When you had discordant results, what actually told you what was going to happen to the patient? And we got an answer. So histology, if your histology is grade 4, that trumps everything. You're going to do badly. If your histology and your scan both say that you've got a lower grade tumour, you will do well. But if your histology is lower grade but your scan looks worse, you're going to do the same as what your scan looks, not what your histology looks. And that then becomes very useful because, firstly, we perhaps would treat those patients more aggressively, which we wouldn't do in the past, and it helps us with decision-making for the patient. And so just this month, I treated this patient who in February had this tumour, which looks absolutely low grade, no contrast enhancement, very typically low grade. So we did a biopsy and the pathology came back as low grade. And so because it's in a very eloquent area, we left it there, and because she was over 40, she got a bit of radiotherapy. But then it started to look like this, and this is June, and then this is July, which it looks very much like a high-grade tumour. Now, actually, I've rebiopsied that tumour, and the pathology is still grade 2. But we know from our research that we need to treat her like a grade 4 because she looks like she's got a grade 4 tumour. And so that research has become practically useful for us now. So firstly, because we know how to ask good questions. Secondly, we have the patients and the tissue, which, let me tell you, is what people in the labs really, really want. I've got someone flying up from Canberra every 2 weeks at the moment to get some brain straight out of one of my patients for their neuron research. So we have the tissue, and I tell everyone in my department, whether they want to be researchers or not, that it is against the Geneva Convention to remove a piece of tissue from a patient and not bank any spare into some sort of a tissue bank. So even if that's your only contribution to research, collecting data about patients, and this is just one of the data collection sheets from our data bank of all the tumour patients seen at the Royal Melbourne Hospital, which now has 1,000 patients with various types of tumours in there with pretty good clinical data. I mean, it's hard to collect, it's difficult to get follow-up, but pretty good clinical data, which we've made into the workflow of our day-to-day care of the patients. And these are neurospheres made from brain tumours taken directly out of patients, fresh tissue taken out, and we also bank in liquid nitrogen a little bit of pretty much everything that we take out if we've got enough. Now, this has led to lots of things, and I'll just go through this fairly quickly because I did talk about it last year, but we've got the Parkville 16 glioma stem cell lines, which we can now use for various types of brain tumour research. When tagged with a fluorescent tag, they make a very nice model in this little mouse. Where we can see the tumour growth and analyse it using bioluminescence in vivo to see if any treatment that we try in the mouse is actually effective. That's one of our projects, but just by having tissue and by having data, we can ask questions and have had a lot of useful questions answered over the years. So I'm just going to show you the titles of some of the research we've done. The fact that IDH1 mutation is associated with tumour-associated epilepsy in patients with low-grade tumours. The fact that this is one of the earliest papers to show that metastases may have a different molecular profile to the primary tumour when they go to the brain or the lung or the liver, and that certain subsets of cells are the ones that will eventually metastasise and probably need to be targeted differently. We can do quality control on our treatment of patients, and in this one we look to see if socio-demographic factors changed how we treated our patients. Did you get more tumour resections if you were richer or more educated or from a better postcode in our practice, and or treated in the private hospital versus the public hospital? And luckily we found out that you didn't get more resections, and clearly we're very good people, but it was a good question to ask. And also that glutamate is perhaps one of the molecules associated with tumour-associated epilepsy, the scourge of our long-living low-grade glioma patients. And this was some of the early work that's now led into clinical trials of anti-glutamate agents for the treatment of tumour-associated epilepsy. You can find out interesting stuff like this, which is we asked, well, does being in a clinical trial, no matter whether you're in the placebo arm or whether you're in the treatment arm, does being in a clinical trial make you live longer from your brain tumour? We thought, well, we'll see. So we had a look at that. And these were our survival curves, and it certainly did look like, of our 540 glioblastoma patients, 12% of whom were on a clinical trial. Now, 12% looks pretty bad. Actually, that's pretty good for a national average. But we would obviously like it to be more. That's probably about 50% of the patients who were eligible for a trial, but 12% of the total. It certainly looks like they did better. But that might just be, is that just because we enrolled all the younger, fitter, healthier patients into clinical trials? Well, no, not on our multivariate analysis. Clinical trial participation still came out as being important. Now, this has been shown in other cancers, ovarian, and just in general in cancers, but this was the first time that it was shown in glioblastoma. So just collecting tissue and data can be your only role, and then asking some good questions. Doesn't mean you have to go into the lab. So what were the reasons that we had? We had that we asked good questions, and that we have the patients and the tissue, and the next that there's some research that only we can do. You know, there's some surgical questions that I think only surgeons know how to ask, and when you see non-surgeons ask surgical questions, you sometimes think, that's kind of dumb. So, you know, I think we have to ask those questions. So this is one of my brain tumour surgeries. For the people who weren't here last year, don't answer if you weren't here. If you were here last year, what do you notice about this patient? Finger to his nose. He's scratching his nose, so he's awake. Yes. And so there's a lot of research that we're doing at the moment about brain mapping and imaging of brain mapping that really, through an awake craniotomy for removal of tumour, there's not many other ways to get this data. It's hard to get control subjects to just have a craniotomy and have their brain zapped. So there's some research that only surgeons can do. And the best example of that, I think, is the research done by this man, Walter Tumor. He's a very good-looking, very tanned German neurosurgeon who, as a neurosurgery resident, thought, well, how can I make it more obvious to see which bit of the brain is tumour and which bit of the brain is brain? Because it doesn't come colour-coded. And he thought, well, OK, maybe I'll make it colour-coded. So he started as a resident in the lab, and he started using this substance called 5-aminolevulinic acid. And he started in the dish, and then he went to the mouse, and then he went to the person, and then he went to phase 2, like phase 1, then phase 2, and finally did a phase 3 study where the patient is given a drink of this 5-aminolevulinic acid 4 hours preoperatively. That gets taken up into metabolically active cells, so that's different from normal brain to tumour. It gets metabolised to photoporphyrin 9, and when you have white light, you can't see it, but when you put your blue light on your microscope, it glows red. And so it helps you to be able to identify what's tumour and what is not tumour. So here we are. We call this the blue light disco operation. This was the first one performed in Victoria. Here is from the survival curve. So basically his phase 3 showed that you were twice as likely to get a gross macroscopic resection of the tumour using the 5-aminolevulinic acid. And secondly, that there was an improvement in progression-free survival. Now, the trial, it was not powered for overall survival. So, you know, real bench-to-bedside research with a question that I think only a surgeon could have asked. And that's now standard of care, really, across Europe, increasingly in Australia, and it's just been approved by the FDA in the US. So, you know, fantastic. Why would surgeons do research then? Well, you could do it just so that you seem smart, although I must admit that working with some researchers has pretty much made me feel very stupid because there's some very smart researchers out there, especially when they show these diagrams. Oh my goodness. The pathway diagram, the ones that really actually look like the Tokyo subway map and are about as decipherable to me. So don't worry if your eyes glaze and roll back in your head when you start to see the pathway map. That's for very special people. You can still do research even if you don't understand them. Because you want to be cool, I mean, you know, best line in a movie in the last, 12 months from The Martian, you know, I'm going to science the shit out of it, you know, best line. So that you could seem cool. Matt Damon, I mean, you can't be cooler than that. Because we really do need to fight the forces of evil. I think that's a very important reason to be a clinician-scientist. But why really? Really, because I don't think you can provide good clinical care or great education without having that other leg of the tripod, which is research. It's the way that you can best contribute to your patients if you care for them, but if you get new knowledge in your care for them and teach others to do so. So I really think you've got to do all three. And this is just a slide from another talk that I gave on a similar thing. If you do research, it makes what we do every day in caring for patients, it makes it matter. Of course it matters to the patient, but it makes it matter in a more global sense to patients of the future. And so just one last piece of research that I'll talk about that's just a very basic way of doing surgical research. You know, we all have to do the MD research project or scholarly selective projects, and I thought to myself, how am I going to have one of these that I don't have to come up with a new ethics proposal for every year? And oh my God, that's going to be so I thought, okay, that's it, 5-year longitudinal study, fantastic, no new ethics. So why don't we look at the quality of life of our patients who've had low-grade tumours or benign tumours removed, just longitudinally, not in a clinical trial, not in anything else. Why don't we just say what happens to these patients over 5 years with their quality of life? And that sort of came out, and so this was, you know, the first year when we collected 500 patients. It came out of some research that we'd already done by this very clever neuropsychologist who worked with this for a while that showed that, you know, definitely our patients had problems with social functioning, with emotional functioning. We knew that was true. So, you know, why don't we have a look at it longitudinally? Because most people hadn't looked at sort of one patient over 5 years. They'd looked at one patient who was 1 year and one patient who was 2 years and another patient who was 3 years and tried to amass it. Why not do that? And we've started to find some really interesting things. We're 4 years in now. We've got 500 patients. It's the largest quality of life cohort for brain tumours in the world. And so it's starting to be a really big data set. We've found out that our patients have quite bad quality of life in one way of looking at it, but not as bad as you might think. So those colours are the tumours. Those colours are the normal population. So even normal population doesn't have normal health-related quality of life. They don't rate themselves as 100%. So many of our brain tumour patients are not much worse than the normal population, which was surprising. But the spinal patients who've had a benign spine operation, oh my God, they rate their quality of life as being absolutely awful. So we're exploring that a bit further. I'm going to go through this. What things in our brain tumour patients, though, are related to poor quality of life? Well, those things, which are pretty obvious, but also this idea that their brain's not working, that their cognition is poor. And what's that associated with? Well, these are some of the things that we think are associated with it, but we thought, well, is their cognition actually poor? They look pretty normal to us. So do they really have poor cognition? And so we looked at it with MMSE and found some interesting things, that people who had really pretty normal MMSE scores were scoring themselves very badly on a cognitive quality of life domain score. Okay, all right, well, I don't know, what does that mean? Is MMSE just a blunt tool? It's not a great tool to use. But we had all these interesting groups to look at. People who scored normally and did normally, people who scored in the middle but seemed to have a normal MMSE, these people down here, and some people who clearly were cognitively very bad but thought they were okay. So we had some interesting groups to look at. So then we started using an online cognitive performance battery, CogState. It's used in lots of different sorts of research. And we found, again, we've got this group here who, although they've got they score pretty normal on the CogState, which is anywhere between 90 and 110 would be considered within the normal range. They themselves think that their cognition is actually pretty bad. So we're just starting now to tease that out. Is it fatigue? Is it psychological, depression, anxiety? Is it sleeplessness? And we've got sub-studies going for all of that. So that is just a very simple thing, which is now growing like topsy. I've now decided we're going more than 5 years. We're going out to 1,000 patients so that we really have a massive data set that we can use to try to answer all of these questions. And this has just been fascinating, just from, really basically a bunch of medical students giving someone a questionnaire in the waiting room and putting it in an Excel spreadsheet. So you don't have to have rats. Anyone can do a little bit of surgical research. Very happy to take questions.
Thanks very much, Kate, for a wonderful talk. Even better than last year. I was here last year. Questions for Professor Drummond? We got microphones?
No one.
Thanks for an interesting talk. I'm an honours student who's doing like a prospective clinical research project this year. And I found that one of the obstacles I face is that a lot of people that you encounter perhaps don't value the work that you do or why you're doing it. I'm wondering if this is an obstacle that you've come across, and if so, how have you dealt with people like that?
Can you give me some more details about what you mean by don't value it, or?
You know, if you have research, other people, you know, find that, you know, research is an obstacle or like a hindrance to like their everyday practice?
Look, I mean, I think everyone is busy. That's true, and I think there are some people who really are not going to contribute research in a big way, although they should still be contributing sort of data and tissue in surgery. I think I'm very lucky in that I've always been in academic sort of centres, and most people are pretty on board about it. But of course, it does take a mindset to you know, allow that researcher to go in and ask the questions before you see the patient in the clinic or whatever else, and that can be a bit tricky sometimes. Yes.
Good question. Any other questions? Down the front.
Thanks, Kate. I think that's a wonderful example of the challenges of a surgeon and clinical research. Tell us what you think special... I mean, you've sort of touched on why surgeons should or shouldn't do it, but tell us some of the challenges you've met personally as a surgeon wanting to do research, the personal story a little bit.
Oh, it's time. You know, it's time. So, I mean, so surgery, you've got to operate. And when you operate, you know, that's 2-3 days a week where you don't take phone calls. You can't duck out for a lab meeting. I mean, occasionally you can if you've got, you know, a good trainee or whatever, but time is very difficult. And then in Australia, protected research time is sort of non-existent, really, especially if you're largely in hospital-based practice. So I was just in University of Toronto, you know, sort of picking the brains of who would sort of be the most famous neurosurgeon, clinician-scientist in the world, and saying, well, you know, how do you do it and whatever, but he's got 2 days of protected research time. He only does 100 cases a year. I do about 300 cases a year. He doesn't do it on the sort of on-call that we do. The structure is so it's all about time. It's all about how are you going to make it fit in. So you've got to be very pragmatic about it.
Yep.
How do you make it fit in? 3 a.m. You get a team. So I have found it to be fantastic to get medical students, you know, registrar projects, whatever, medical students in particular, because they've got so much energy and time. And what's that thing you have on your calendar? White space. White space. Who knows what that is? Anyway, so I think build a team, ask good questions so that, you know, you're not doing stuff you're not interested in. Use the resources that you've got. I mean, if you've got a whole bunch of patients with this thing, do your research in that thing. You know, I think it just be smart about it. But there is a lot of, you know, writing the paper at 3 a.m. There is.
Yeah.
You mentioned at the beginning of the talk that even those people who are in the study, regardless of whether they're on the placebo or the actual treatment group, showed a better outcome. Mm-hmm. What factors do you think are involved in that just being on a clinical trial helps with them?
Clinical trial medicine is good medicine. The patients are cared for incredibly well. You know, they have all the blood tests, all the problems are picked up early, they're seen often, they're scanned often, you know, they're looked after incredibly well. And so, you know, that's why you need to have a placebo-controlled arm, or for surgical research, a sham surgery arm, because you know, any treatment, whether it works or not, because of the care given to the patient, will improve outcome in some way.
One last question and then we'll move on. How loud's your voice? Sorry, we do need the microphone.
Thank you for your talk, Kate. As was pointed out earlier, you're a woman in neurosurgery, that kind of an easy. Have you noticed a change over your career in I guess, opportunities open to women, and what kind of things have you had to face along the way?
So I was the 4th female neurosurgeon in Australia and New Zealand, and so I guess the change that I had really no female role models. I mean, I did, but I didn't, because the people around me directly were all men. That didn't seem to be a problem. I had fantastic male mentors and role models. But things certainly are changing and opportunities are changing. I've been very lucky to have been given really great opportunities. But this year in neurosurgery, 4 of the 6 people who got onto neurosurgery were female. And so in like 50 years, when all of the old men die, things will be a lot better.
That last sentence was a fabulous way to end. Thanks very much, Kate. And as I say, even better than last year. Look, I think Professor Drummond convinced us of the critical importance of data and evidence in improving the way we treat neurosurgical patients. And our next speaker, Professor Grant Russell, who's the head of School of Primary Health Care at Monash, a general practitioner, and again, very concerned, I think, with data and evidence-based medicine, but in this case, more related to primary care. Grant.
I'm just going to pour myself a glass of water. Always very humbling, these things, because you sort of just hear about these parts of medicine that you just read about in the paper, and then you see some photographs of things like radio illumination of brain tumours. So very impressive. But I'm going to start with acknowledging the traditional owners of the land and pay my respects to their elders past and present. I'd like to reflect that I always do as I'm told, and fortunately my boss, Chris Mitchell, has just left. She's had to take her mum out to lunch. And I've been told I've got to tell a bit of my story and to give some research examples that might illuminate maybe a different way of looking at research and looking at life as a clinician-scientist. Because you're not going to hear about zebrafish, you're not going to hear anything about any machines, big technological machines, and those 4-letter sort of gene thing, you're not going to hear about that either. What you are going to get is a painful personal confessional. I'm going to show you that you can do research outside the safety of the hospital and the safety of the lab. I'll talk about some recent research around the way the primary care system works and some personal reflections on the journey. But first of all, I just want to talk about primary care for a second. And this comes from a 1961 article in New England Journal of Medicine. It was a really interesting method. So this guy called Kerr White pulled together a whole lot of data sources, and he would have done this without computers, and he worked out what happens to 1,000 people, the average 1,000 Americans, over the course of a month in terms of their health care. 800 of them report symptoms. 800 have symptoms where they would think about getting some help from someone. Of those, of that 1,000, 113 in the US and more in Australia visit a primary care doctor. So primary care in Australia and doctor you could equivalent to a GP. 13 to go to an emergency department, and 1 ends up being hospitalised in an academic medical centre. It's no real surprise to any of us to know where all of our training is, all of our experiences, right in that little bottom red dot. The world of primary care, I'd call that the GP should space. So that's the space where we're often told, well, you should be doing better prevention on those people who don't notice symptoms. You should be managing those early symptoms better. Or as in the Age yesterday, you should be prescribing less antibiotics or seeing people so they don't come to our emergency department and the politicians ask questions. So it's a funny sort of world. It's a different world, and it's a world outside those big, shiny institutions. Never better, I think, exemplified than with a photo essay in Life magazine, which I think is closed now, Life magazine. One of the great photographers of the 20th century, W. Eugene Smith, followed round a family doctor in rural Colorado for 3 weeks and just took snapshots of his life and his experiences. And for at least your parents and for many of us, it's that concept of the personalised care with a family doctor that exemplifies what they think a GP is. But regardless, doesn't matter whether it's sitting in a practice just outside of here or back in rural Colorado, what's unique about primary care, if you just think about it for a sec, there's only a few things. But it's the only part of the healthcare system where doctors can be seen at first contact, so you've got a problem, get to see a doctor, and where there's continuity. When you go to see that doctor, you will see them again and again, or there's the expectation to see them again and again over time. That doctor's got a job of pulling together various parts of the healthcare system in caring for you, and that there's an expectation that even if you go in with a headache with one of those glioblastomas, that the doctor's got enough skills and understanding of the system to be able to deal with that problem. He can't say, that's nothing to do with me. So, we'll come back to those in a sec. But till not that long ago, general practice was all about these little interactions. Small practices, fee-for-service, relationship with everything, big focus on acute care, emergencies, things happening. But it was a system that was in trouble. I'm going to come back to that system. But firstly is that painful professional confessional. So I did 1983 MBBS in UWA, residency at Fremantle Hospital, which explains my football supporting tendencies and lots of arguments I've had with Chris Mitchell, the Hawthorn supporter, over the years. She always wins, sadly enough. Wandered around the subcontinent like a lot of people of our age, worked a bit in the NHS, did GP training, did general practice in Perth. I really enjoyed doing general practice obstetrics and doing palliative care, sort of as a sort of young GP. But it was getting harder and harder to do any of those things. You're moving out of hospitals, hard to do that stuff in hospital anymore. And then I sort of started dabbling with a few things, a bit of teaching, a little bit of research. But things, it was like I needed to add something to the clinical life that had developed. And I had a contact with clinical research, and it was a really interesting contact. And here is a question. Does anyone know who the man on your left-hand side is? Anyone? Barry Marshall. Barry Marshall, who discovered Helicobacter and had a spectacular series of experiments, was my registrar for a few weeks at Fremantle Hospital. Barry was a pretty remarkable fellow, and I'll tell you Barry's stories at lunchtime, if you like. But I like this quote from Barry. He said he was constantly mucking around and with irrelevant side issues, which he often found to be more interesting. And in a way, that could explain part of that 10 years or so with trying various things that I was doing. And Barry ended up somewhat spectacularly with a Nobel Prize with Robin Warren. But while he was swallowing Helicobacter and satisfying Koch's postulates, things were really getting problematic within primary care. Graduates were less and less keen to want to do it. Incomes were falling, or at least static. There was hardly anyone doing academic primary care research in Australia, And then, as often and strangely happens, something big happened in the US. And that was the release by the Institute of Medicine of a really groundbreaking report that held the mirror up to the quality of care in the US. They said, Americans don't often do that. We have a fundamentally flawed healthcare system and we need to work on evidence into practice and quality. And it's with that was almost like a similar reports were released in a whole lot of other countries. And at the same time, we began to have a look at how good primary care was doing, about how it was performing. So we began to discover that that chaotic, messy world of primary care was intimately associated with improved health. So a series of groundbreaking studies. If you are in an area that's got good primary care compared with another area, you will have improved neonatal mortality or cause mortality. The gap between rich and poor will diminish. A whole lot of other outcomes have come over subsequent years, which are listed there. It costs a bit to get it started, but it puts a cap on spending. And that, for health policy makers, is really important. I found it really interesting. But there was nowhere really in Australia to do it because it was starting the primary care reform bus. And my way of getting on the bus was to win an overseas PhD scholarship. So the destination for the bus was a new way of delivering primary care, and that was the patient-centred medical home. You hear a bit about this. Australia's doing a trial of healthcare homes at the moment. Talks about personal physician, so valuing those aspects of having a doctor, or at the very least a place you can go to, that it pays people differently. So we don't make money, we're not meant to make money as family doctors by churning people over, but there's meant to be a way that there's quality that can come out of the way that we're paid. Care's coordinated, evidence is brought into practice, and that there's teams. So that's where people have been trying to move all over the Western world. It became really interesting for a lot of people. And for someone like me who'd been working in the system in a frustrated sort of way for a while now, for a decade or so, I thought I really want to have a look at this, and hence the PhD. So it took me from life in WA, which is fairly idyllic, and this is a 1 month before and after photo, to life in Canada. I asked a few people, a lot of people actually, where was the best place to go to do a PhD? They all said the Centre for Studies in Family Medicine in London, Ontario. It was really a leading site. It was the leading site really in the world for family medicine. You've heard, probably suffered with, the patient-centred clinical medicine method, but it was developed, articulated and tested there. And I always remember that they used to say that the evidence behind the patient-centred clinical method and outcomes is as strong as the link between beta blockers and improved outcomes in heart failure. It was a place where instead of just a sort of little chaotic, demoralised academic community, there were people who were there who really wanted to be there, who loved asking questions and had a common vision. It's a very inspiring place to be. There for a couple of years, went back home for a year or so. Then the phone rang with a very unusual thing, which is where my boss-to-be said he had too much money and not enough people to do the work. So after tossing around for a while, I went to a primary care research centre in Ottawa. And this was sort of in a way the dream, because they were looking at primary care reform, looking at measuring performance, using big numbers, trying to actually improve practices. Told us that we could be a bit entrepreneurial, but entrepreneurial often has to happen in this field with government. And it's not just general practice. It's about nurses and others as well. Ottawa's an interesting place. Anyone, who's been there? Anyone been there? Oh, you've got to go. There's someone down the back. Second cold, it's second for everything, Ottawa. It's second coldest capital city, second longest skating rink, which is about 6 miles long, by the way. You will have heard and struggled over the Ottawa ankle rules, I'm sure, and a couple of other a couple of other Ottawa rules, but it's the seat of the federal government. This was actually a view outside my window at work, which is pretty good. The federal government had a critical question. What is the best way to organise and pay for primary care? How do you do it? And this is the first bit of data I just want to show you. So, and Ontario turned into a laboratory. So in Ontario, there were 4 different ways of organising practices. This is general practices. There was typical fee-for-service practices. There was another group called HSOs. There was community health centres, and these big new model which the government was investing in. Sort of looked like this healthcare teams, etc. Shows that the community health centres had a lot of nurse practitioners, nurses. The family health networks had nurses in them as well. But the big difference was how they were paid. Fee-for-service, paid by fee-for-service. Traditional little practices. Capitation was the way that health service organisations were paid, and that's where the doctor gets a bunch of money for caring for the patient for the whole year. Community health centres, you just get paid to go to work. Doesn't matter who you see, how long you're there for. And family health networks were a bit of a mixture. So what Ontario really wanted to know was which was the best way of delivering care. So we then were funded to try and find out which are the factors in a practice that really made a difference to quality. Typical sort of quality list there: chronic disease management, prevention, access, health promotion. So what we did was a big mixed method study, 137 primary care practices across all of the models of delivery. A whole lot of providers and a whole lot of patients. We sent researchers out to every one of those practices, patients filling in questionnaires, providers filling in questionnaires. We got a bit of admin data. So what did we find? So the independent predictors of quality chronic disease management, like better diabetes care, better heart failure care, was having a nurse practitioner in the practice increased the quality by about 10%. Large practices, bigger than 4 family doctors, got worse by about 8%. And the busier the practice per family doctor, the worse the performance. The model didn't make a cracker of difference. So it was what was in the place rather than what it was called or even how it was paid. Okay, so we had a lot of outcomes, and this is just one of those busy slides that people like showing you. I've got a busier one to come. So there are outcomes that we're talking about and dimensions down the left-hand side. As far as prevention, it was different. Female providers seem to be an independent predictor of better preventive care and support from an EMR, electronic medical record. Just let's have a look across the road, because you can see that workload, number of patients per provider, certainly seem to be hitting on quality at all sorts of domains. Always worth looking at females, especially in a day like today, because we've hit some really good gender equity discussions. Might have some more after this. Okay, so we had a very granular way of looking at workload. What was the next? The next thing we did was a big study. We got 8 million records and tried to find and linked a whole lot of databases to try and study, well, what happens to quality when you see more patients per family doctor? I told you there was a busy slide to come. Basically, clusters of screening results, series of chronic disease results, a series of access results. The short answer is hardly any difference at all. So when measured by big administrative databases, there's minor quality associations with bigger size. There's no threshold, so it doesn't fall off the cliff once you see 2,000 or 2,500 patients a year. There's a bit of type 1 error, because you would have seen there were some significant results there, but they're fairly meaningless because of the population size. A couple of other things around continuity. So you needed to have a middle panel size to be able to, for people to be able to continue to go and see you. If you're too small, people didn't seem to come back as far as too big. So the question was, how is quality being preserved in the really big practices? And what does that mean for a government who's trying to make some recommendations about workforce and how many doctors to provide? And now, physician gender and quality of care. What sort of difference does that make? Same study, same process. But here's a relationship between the gender of the GP and the quality of care over 5 dimensions. All right. So this shows we've got effect sizes on the right-hand side. So you can there just for colorectal cancer, which you wouldn't think would be any different between male and female screening, 24% better screening rates amongst patients going to female family doctors than to males. Female patients attending female family doctors less likely to go to hospital, a little bit more likely to be referred for specialist care. No differences in continuity or comprehensiveness. There was some gender concordance, so the males did better with male patients and the females did better with female patients. So what are the implications for that, for training and workforce and how we organise our care? What are the policymakers thinking? Well, there's some pretty strange stuff going on. There is some strange stuff going on. As Donald Trump, and he's picked this up, that he found out in February this year that it's a very complex subject and no one could have known that. So, talking about complicated, I'll tell you what's complicated is trying to entertain children when there's snow on the ground in Ottawa for 7 months of the year, and that's our swing set. And it was just about this time after we'd returned from a holiday in Perth that it was time to look at going back to Australia. So what happened was, we moved to Dandenong. There was a job advertised by Monash where they brought together a partnership of a health service, Monash Uni and a GP association. There's money for myself and a half-time research assistant, and I did have an office, and that was about it. I think if I had that offer now, I'd be looking very concerned at it. But we had a lot of support from the 3 agencies. And maybe this is a bit of an example for those people who are thinking of being outside the hospitals, that there is support around there because people want to have their work informed by policy, by research. It was based in Dandenong, huge amount of refugees in Dandenong, over 1,000 new arrivals a year, most of them young, and they've got complex physical and mental health comorbidities. The region wanted to just use research to do some system improvement. So our unit that we set up was asked to try and shape the system of primary care to improve the well-being of disadvantaged people. And so really what we did over the next 5 years without really much money was to try and just build partnerships with people on the ground. We'd found $10,000 to do a needs assessment, which is actually a really good thing around refugees because it allowed us to open the door to getting some new grants. So we had a little bit of seeding money from Monash Uni, a bit of other money from the GP Association. And we spent a lot of time trying to build our links with the community. We employed a refugee, a man who came knocking on the door and said he was wanting to do some work, and he used to be a health bureaucrat in Afghanistan before the Taliban had kidnapped his brother and he'd left the country. We learned a lot in building this all up from our students, our medical students. We learned about how refugees, their whole experience of healthcare is influenced by what they've experienced in Afghanistan, because of a big Afghani population at the time. They really wanted medications and tests when they went to the doctor, especially in the first 12 months or so after arriving. But then after that, it sort of started to get a little bit more back down like the usual population, the rest of the population. And health literacy, teaching people about the system's really good. There were some big programs going around with this. but it was clear that you couldn't learn much until you actually went into the system. And dependence was always an issue. So we then got a bit of money to a systematic review, and we designed a model of care. And the systematic review sort of showed some really interesting stuff around access, that the big things to help refugees access care is having staff in the practice that have at least got an opportunity to be bilingual, or that you can use interpreters. And we've got a wonderful interpreter service in Australia that's underused. That case management is one of the few times that case management actually makes a difference with refugees. And that cultural sensitivity, so people like all of us knowing more about the refugee population is going to help us do better. And again, appropriate use of interpreters. We looked at refugee care right across Australia, and we've identified the issue of inadequate access, that there's just not enough really high quality services to help people, especially outside the big cities. That people will get stuck in services and they wouldn't get out to mainstream, and then people were worried about mainstream quality. And so all of that eventually ended up with a lot of time and a lot of writing. We got a $2 million NHMRC partnership grant to trial a new model of refugee care. And that's been able to bring all of these disparate bodies together now in 2 states, 2 regions of Melbourne, to be able to see if we can get a different model and a different approach to delivering primary care. And that's the aim of the study. It's going to be a randomised trial of trying to use facilitators in family practices. Okay, so there's a little journey. There's not been too many figures, no genetics, but what are the take-home messages? From what's been a sort of a jigsaw, and I reckon that's what it often is for a lot of us, particularly outside of the big teaching infrastructures of hospitals and research institutes. You know what I think? I think you've got to be an excellent clinician. I think it really matters. I put an asterisk there because there are those that say, well, look, if you're going to really do great research, it's a waste of time seeing patients. But I would really challenge that. I challenge it because you become less relevant, particularly in the eyes of those who you're working with. So if you're working in the world that I work in, not seeing patients is really challenging. I think it's different in other parts, but I'd really stress the quality of your clinical work, to never leave. I love seeing patients, see them every week. I would go away. You've heard a bit of this. It was funny coming back to Monash after being overseas for 6 or 7 years, and there's people who have never left the institution from being a medical student. So give it a go, because it is really worth it. You learn a lot about yourself. There's a bit of an allusion to this earlier about research scientists, and I think Kate said something about a social scientist who she'd been doing some work with. We as doctors primarily learn to be doctors, and then we add on a research career. A research scientist, often from when they're 18 or 19, are focusing on learning a deep understanding of doing research. And that's particularly around social science. They are really valuable for us. Get into the field, get your hands dirty, collect data, analyse data, look down microscopes in other worlds, learn how to write, know why you're putting yourself through this and your family. Remember how lonely the higher degree can be, how important a supervisor is, and of a team, and of bringing your skills to the table. Think about the organisation, and a couple of little take-home quotes. So much of it's about relationships. I do apologise. Now it probably should be, this is a mentor of mine. He said, I'd only ever do research with someone I'd have a beer with. And that's because it's frustrating and long, and you've got to have a relationship with the people that you're doing these long projects with. I think now you'd say, someone I'd have a decaffeinated soy latte or something like that. Martin Bass, great primary care academic, has written that no one but ourselves, and that's clinicians, will ever know our needs and our patients' needs. no one but ourselves will answer our questions exactly. I'm going to just leave you this quote from Mark Twain, which, true story, was the final thing that made me decide to go and start the journey. It's a great quote. It's a good thing to have a think about. Thanks very much.
Thanks very much, Grant, and such a wonderful talk, a completely different talk and career experience. But look, we've got time for one or two questions. Yes, down here.
Sorry, the potential impact once you get bogged down?
Yeah, once you start working through the actual project.
Okay. So, yeah, it's interesting. I mean, the world of public health and the world of primary care they're different worlds, but there's a big intersection across the two of them. I guess what do? You've got to listen, you've got to read the paper. You've got to look at what comes out of government. You look at what way the wind's blowing. And I think that's probably the best description of all. It is a world of healthcare policy, which is then policy into practice. So those are the things that you need to be listening to. The second half of the question about what do you do when you get in the midst of it as far as translating, I think that really implies keeping links with policymakers, decision makers and clinicians. So I do a lot of work with Monash Health, and the most important meetings I have are with the operational people at Monash Health. So how can we make the things we've learnt get translated into practice?
Yes.
Okay, thank you, Prof. Grant. I just want to ask a question as a general practitioners, and as from my practice, I see a quite significant portion of the junior doctors nowadays are choosing to go into general practice. As you have said, there is a very, you can say about 80% of our patients have been first approached by a GP, and they are resolving most of the issues. But as most of the research now is surrounded from this meeting and from the other meetings, you feel that all the research are contained within hospital. So my question, as many of the junior doctors now going to be a GP, how we can, you can say, empower them to be researchers within the GP practice, and how, what's the you can say, the options that they got to contribute to the health system in the GP?
Yeah, it's a good question, and it's sort of one of those things where it's a responsibility of departments of general practice, of family medicine, of schools of medicine, of faculties of medicine to be able to help promote these, of colleges to promote these things. But there's quite a bit of work done around what are called practice-based research networks, which is sort of hubs of research interest in communities. And there's some really great ones around where collections of GPs with a bit of an interest say, well, I really want to know about such and such. Can we do some research on that? Working with an academic environment with a little bit of money can sometimes get some remarkable outcomes. I'm happy to talk about that with you later. There we go. Thank you.
Thanks a lot, Grant. There have been some very strong themes this morning, I think, around the importance of evidence and data in research, and the importance of being able to translate that evidence into social and economic benefit and improve patient care. And our third speaker is Professor Stephen Tong, who is an obstetrician and gynaecologist and head of the Translational Obstetrics Group at Mercy Health. Stephen. Thank you.
Okay, thank you very much, Ingrid, for this very kind invitation. It's quite humbling given the calibre of other speakers. I do notice in your book before we start, page 11, there's an empty area for pearls of wisdom. You can probably put that book away for the next half an hour and probably just listen and hands-free. So I would consider myself a clinician-scientist split right down the middle, and I have a group who I'm immensely proud of, which we call ourselves Translational Obstetrics Group. And we're a group of 10 to 15 of us, and we have an extreme focus on laboratory investigations that we can translate to the laboratory and into clinical care and clinical trials. And we've taken 2 or 3 concepts from the laboratory into clinical trials run across the world, and I'm happy to share them with you today. I'd like to start with the first concept that I'd ever stumbled upon. And this is to treat a very important pregnancy condition called ectopic pregnancy. So 1 to 2 of all pregnancies never make it into the womb. Instead, they embed in the fallopian tube. And they're never viable, but they can rupture in the fallopian tube, causing a catastrophic bleed. So they're a gynecological emergency, and most are treated surgically. And this can be very successfully done in the developed world, but in the developing world, it may be not as accessible. And even in the developed world, occasionally we have very catastrophic outcomes from misadventure. So in the last 20 or 30 years, there's been a medical alternative to try to avoid surgery. This is the injection of the chemotherapeutic agent methotrexate. And we have a methotrexate protocol which some women are eligible for with an ectopic pregnancy. And it works very well for small ectopic pregnancies, but its effectiveness drops rapidly with a larger ectopic size. So most ectopic pregnancies are just too big. They're not suitable for surgery. And this is somewhere where a more effective medical treatment could make the treatment of ectopic pregnancies much safer, much more women could avoid surgery. So in 2008, I was in Brian Williams' cancer lab, which is now the Hudson Institute, and I was leafing through my trusty New England journal, which I was a subscriber, and I chanced upon this article, which talks of an epidermal growth factor receptor antagonist. And in particular, there's a tablet called gefitinib, and it blocks this potent cell survival pathway. And the reason that this caught my eye is that I knew that the placenta had the highest expression of this epidermal growth factor receptor, and the placenta is absolutely addicted to this pathway to survive and grow. So given that the placenta has the highest expression of this of any other tissue, in the non-cancer setting, taking this tablet might be effective to zap the ectopic pregnancy. So I thought, oh, this is an opportunity. We could look at whether adding this tablet with the methotrexate injection might work much better and make a more effective way to medically knock off an ectopic pregnancy to avoid surgery. And this concept came to me in 2008, but I had a small problem here. I was half-time doing clinical work, and I do obstetrics, so it's a craft specialty, and I didn't have a laboratory and I didn't have a lab group, so that was a bit hard. So I squirreled together all my small funding, every dollar that I could find, and I put an ad, and this letter came from Sweden, from Ulrika Nilsson, and this is just a beautiful cover letter, and this is the original cover letter, and it's just word perfect, and it just caught my eye of the 108 applicants. So I said, Ulrika, come to Australia, and she joined me, and it was just Ulrika and I. And over the 2009, she did a beautiful set of studies just to show that these medication combo are super additive. Added together, they are way more potent than each other in knocking off an ectopic pregnancy. I got very excited. It was just Ulrika and I wanted to present this at the best world stage I could, which would be the Society for Reproductive Investigation in 2008 in Orlando. But the problem is every single abstract I submitted, I always got a poster. And there's nothing wrong with a poster, but I just hope to get an oral this time. So I took a few strategic steps. I put it into what I thought would be the least subscribed session, found the most obscure topic, and I put it in, I got myself a oral. So this is the original first slide of this presentation that I did in Orlando. Slight problem was my ploy worked a bit too well, and there was just about 15 or 20 people in the room, and half of them were my friends. I could actively see tumbleweed floating through, and I thought, oh, this is interesting. And I actually remember they set the room so awkwardly, I actually zapped the chair with my laser pointer right in the eye. But luckily for me, I think she's okay. She was American, so I don't know. But luckily for me, sitting in the audience was this guy from Edinburgh called Andrew Horn. He was quite young at the time, still is, from Edinburgh. And I looked him up later, and he's Mr. Ectopic. And it just so happened that Andrew was in the audience, and he's become my lifetime, as I say, BFF in academia. And he said, if you want to take this to human trials, I'll work with you. And very excitedly, I got my second NHMRC project grant, and we launched into a clinical trial. And this is taken to clinical trial just a few years after Ulrika did those first assays, so pretty quick. And this is just to walk you through the results of our first clinical trial. And this is just 12 participants, single-arm exploratory trial. And when we treat women medically with an ectopic pregnancy, we track their serum HCG in their blood. We track it down to 0 to show that the treatment has worked and the ectopic pregnancy's disappeared. So in the red are controls, some 71 women who were treated with methotrexate only. So the HCG goes up between day 1 and day 4, which we commonly teach happens, and it's slowly dropped. But we're quite excited to see the women, given those 7 tablets with the methotrexate, the HCG levels just bombed right down. They were 1/5 of the levels with methotrexate only by day 7, and they were cured 34 days faster. And lots of them had successful pregnancies afterwards. I mean, some had the bonus that they had 2 heads, but that was fine. No, the treatment was safe, no teratogenic effects. And then we ran 2 further early phase clinical trials. We treated women with large extratubal ectopic pregnancies, and these are the real nasty passy of ectopic pregnancies. Published that, and it all knocked off those ectopic pregnancies. And then we did a second phase, early phase trial, a phase 2 trial, where we treated bigger ectopic pregnancies. Now, these are women with the criteria that if we didn't enrol them in the trial, they would have had surgery straight away, and that worked very well. And Andrew was in the inner sanctum of the European circuit, and he scored us a dual presentation at this most prestigious of meetings, ESHRE in Munich 2014. And they put me up to this incredible hotel room, and I paid for one night, and it was 400 euros for that one extra night, which almost killed me. I'm still paying it off now. But this was breakfast, and there were these waiters wearing better suits than I will ever own, and they just stand there right next to your table. All the, this is the buffet, and all the spoons are lined up facing the same direction. Maybe, I don't know which direction that was, but one direction. And that's just a beer hall, because I had an empty space in the presentation. It looked tacky. But I had the presentation at Munich, and it was a concurrent, 3 concurrents, but it was a meeting of 30,000 people. And there were so many people in the room, I could not tell you to the nearest 1,000 how many there were. When people asked a question, they were just a dot in the distance. And the stage was about half the size of this room. But we presented the idea, and importantly, the leading clinical trialists in the UK were there. And so they came on board with the concept, and this is 2014. Ulrika did the first assays in 2009. And we put in for this enormous grant for a multi-site phase 3 clinical trial. And Andrew led it because it's through NHS, and he went for £1.2 million, which is a lot of money. And luckily we got it. So this is now moved to a phase 3 clinical trial. And now, happily, starting recruitment end of last year, for which I'm one of the senior investigators and privileged to dial in every month, we're running the GEM3 trial. And this is the setup at Birmingham, which I went to last year. And this is a board, which is very exciting, of the 50 centres that are recruiting for us. At first, I thought that they were recruiting from the North Sea and in France, but I realised that's just to hold up the board. Nevertheless, I think some of those are pretty kosher. But it's designed with very hard endpoints compared to methotrexate alone, and the hard endpoint is whether women will need less surgery and whether ectopic pregnancy is cured faster. And I would argue that if GEM3 yields a positive result, this just could be the standard of care to make the treatment of ectopic pregnancies safer, simpler, and more accessible. So I'm always very impressed by this guy, Steve Jobs. So when we're playing around and lining up to buy the iPhone 4, he's designing iPhone 5 and 6. Okay, maybe 3 and then 4, because he didn't stick around for 6. Okay. Look, he's an inspiration. Maybe when Aidan makes that 3-minute video, don't include that bit for next year's symposium. So when this came out, I thought that we're running Gem 3 right now, but I've just got 2 concerns with Gem 3. There aren't concerns, but there are areas of improvement. Number one, in the developing world, methotrexate injection's good, but it still needs a refrigerator. It would be fantastic if you could just make a tablet-only treatment. And the second thing is that these treatments look to be much better in our early phase trials than methotrexate. But there was still some heterogeneity of response, and there were some that didn't respond much more quickly. My hope is to find a treatment so effective that we can just sort of kapow all the ectopic pregnancies, knock them off super quick. So I asked a Harvard-trained academic, what drugs would you be happy to give to fertile women? Need to consult with collaborators. And Elgene gave a hit list, and I have this amazing PhD student who's not a clinician but just a genius, Roxanne, who screened them all, and from them she discovered vinorelbine, which is just a tablet. And in our hands, vinorelbine is 1,000 to 10,000 times more potent in zapping these placental tissues compared to methotrexate. It is such an exciting opportunity. And Roxanne has run a series of very beautiful preclinical studies, really building the case that vinorelbine may be the next treatment for ectopic pregnancies, just a tablet. And she exposed mice to it, and they were perfectly fertile afterwards. And so I was on labour ward maybe earlier this year, and I ran into Prathima, aka Prathi, who's in the audience here, so to make sure that I had a photo of her. And I want to take this to early phase clinical trials like we did for the first concept. And you need a very specific PhD student for this. You need an expert endosurgeon who can bail us out for the times where we do need salvage surgery. Well, Prathima has been doing high-tech endoscopic fellowship for the last 2 years from New Zealand. So, do you want to do this as a PhD? She said, yeah. And so we're designing the Vino trial to start next year. We got generous funding from NHMRC, and we're very excited. And we're turfing methotrexate. Just 2 tablets of vinorelbine will be our clinical trial. So I hope that I put a few themes in being a clinician scientist. Firstly, it's exciting because you're a detective. And secondly, I just wanted to emphasise the fact that being a clinician scientist, you have a split brain. You understand the laboratory, and you understand also what's needed in the clinic. And this gives us a bit of an advantage in trying to find something which is meaningful. And so our next area of translational research is we're trying to develop a blood test to prevent stillbirth. And I just wanted to put it into that split brain paradigm to give you an illustration why the scientist needs to talk to the clinician in the same brain. And so here's the paradigm here. So this is the scientific side of my, clinician scientist brain, and this is the stethoscope. So I wanted to develop a blood test to prevent stillbirth. So if we did a big cohort study and we had stillbirth as an outcome, it's just annoyingly rare enough, but still an important complication that they have to be enormous. But luckily, my clinician brain tells me that detecting fetal growth restriction will be the key to a stillbirth blood test. And the reason is babies that are growth restricted have a 3 to 4-fold increased risk of stillbirth. You detect them, you watch them, you deliver them, get them out of harm's way. So how do we detect fetal growth restriction in the clinic? Well, we use the tape measure. Everyone's gone to medical school and bored with those long antenatal clinics. I do the antenatal clinics. I'm the doctor on board too. No, I'm joking. So you see that the obstetrician uses the tape measure, and for women who they think the baby's small, they send for an ultrasound. Now, what's depressing, you probably didn't learn in medical school, is that only detects 20 to 30% of small babies. The 70% at risk go undetected. So how about we just do ultrasounds on everyone? Maybe that will detect more babies that are growth restricted at risk of stillbirth. Or there was a big Lancet paper which showed depressingly in this best set of hands in Cambridge, it only detects 57% of small babies. So we've got Teresa McDonald, who is a gun PhD student, just a dream PhD student, really clever, super duper OCD, and she ran this FLAG study, which was a large prospective collection of 2,000 blood samples. And we collected the samples very carefully. My scientific brain knew that lots of biomarker studies fall down because you can't validate. So of the 2,000 samples, we've split them in half. We go mining among the first 1,000 samples, and whatever we find, we go for the second 1,000. And we're measuring in the blood RNA and proteins, and I won't go through the boring aspects, but I've thought long and hard what we would look for, and we're using next generation technologies, but also we're using targeted, clever strategies, I think. We're looking at things which flick off particularly from the placenta. So we bias the measurement of stuff coming from the placenta with the concept that if the placenta is a bit stuffed, there'll be changes in this signature. And we've had a lot of negative data, but every positive is exciting. And so far, with the cluster of 3 proteins, we've so far got a detection rate of 54%, which doesn't sound a lot, but we're very excited by this. This is already better than the clinical standard of care and almost matches ultrasound on everyone, which is something that we don't do because it's just so expensive. So the strategy and the focus is very simple. We're going to try to get that detection rate by adding more proteins and RNAs we discover up to 70 to 80%. Then we'll unleash on the second 1,000 samples and validate. We have an industry partner who's very interested, and I'm super excited about this. We just might be able to nut it out. Probably our group's biggest concentration is developing treatments for preeclampsia. This is one of the major complications of pregnancy, which still claims the lives of both mothers and babies. And again, this is hopefully making the demonstration that this is understanding the clinical need and what is possible in the laboratory. So in 2006 and 2004, a Harvard group published the toxins which come out of the placenta, attacks mum's blood vessels and attacks mum's organs. So I've just come on the scene at the right time. There's a druggable target. It's called S-FLIT and soybuindoglin. So if you somehow decrease the placental production or you can neutralise these molecules, you may have the treatment for preeclampsia. So group went nuts with antibody technology, peptide technology and nanotechnologies to try and switch off the production of these toxic molecules. And we're still attacking these, and these are very exciting aspects to our laboratory. I've also thought as a clinician, these are exciting, but they are so many steps removed from clinical trials because you need to do safety, and it's pregnant women, a very vulnerable group. So the pragmatic side is we started looking at repurposing drugs which we already know are safe in pregnancy. And we hit upon a few very exciting discoveries. We found esomeprazole decreases the production of these toxins in the placenta. And then Fiona Brownfoot, who's also sitting in the audience, a very, very smart clinician-scientist. She's got a bit of a Steve Jobs force field thing, and she's a bit of a siren for the world's professorial academics, and she doesn't like me telling these stories, so I won't. So I won't mention the poem she gets from a UK professor. And so she discovered metformin, and sulfasalazine drops these toxins. And this is super exciting because now we've got drugs which we know are safe in pregnancy. We can fast track them to clinical trials. So clinical trial number 1, Fiona's running the SIP study, the sulfasalazine in pregnancy study, a pharmacokinetic study. She's going to take lots of outputs in women at Mercy Hospital and Sunshine Hospital. But when we were having these discoveries, we had a maternal fetal medicine fellow come from South Africa, Kathy Kluver. She looked at it all and she said, look, there's so much of a burden of disease in South Africa. I'll run a clinical trial there. So we ran and set up the PI trial, which is looking at esomeprazole to treat severe preterm preeclampsia in a country where the disease incidence is absolutely out of control. And just to demonstrate it, in one centre, Kathy started the PI trial, which is a full randomised trial, and she finished recruitment in just over 1 year. And we're very excited about this, and we're analysing the data. We've done pharmacokinetic data. My clinician brain made sure that we had, my scientific brain made sure we had blood data to measure the S-FLIT levels to see whether they go down or not. And we've moved on to setting up PI2, which is now testing metformin, which were concepts that we developed in the lab at Mercy. But we're super excited because what we've effectively got is a drug screening pipeline from bench right to phase 2 clinical trials. And we hope in the next 10 to 15 years we can find a treatment for preeclampsia. And we're looking at prevention as well. So there is a large number of the major clinical trialists looking at screening and treating, and I'm very humbled to see that we've got the lion's share of the top clinical trialists across Australia who have come on board for the Barista trial. I've actually forgotten what Barista stands for, but it's such a good mnemonic, it doesn't matter. And the nominate trial is metformin to treat preeclampsia in women at high risk, 3,000 women with a high BMI. And the reason why it's called the nominate trial is it doesn't have a name right now, so I've called it innominate. And so we're doing fact-finding. We've got a PhD student that will start it next year. This is metformin to treat 3,000 women to prevent preeclampsia. And so we've got all these hospitals on board, which is very exciting, but I felt that we needed more. So last year I popped over to Chile and met my good friend Sebastian Ilanes, and I said to Sebastian, will you join us for these to set up a bit of a clinical trials network, try to beat preeclampsia? He said, yes, but in one condition. I said, what? You come to my home for a barbecue and you meet my 9 children. So I went to Sebastian's home and had a delicious barbecue and met his 9 children. This is Roxanne from the Atopic Pregnancy study, so she's not one of Sebastian's child, and this is Nat Hannon, who's my senior scientist, but we had an absolute ball, and he does have an amazing barbecue. He's also a top person in Chile, and he's come on board with 3 massive hospitals as well. And so the first concept of repurposing drugs in 2013, now we have plans or have completed 4 to 5 clinical trials to try and treat preeclampsia. So I would conclude on being a clinician-scientist a few things. I think it's an incredibly enticing field for these following reasons. Firstly, it's very exciting to be a detective. You get a result, and if you're lateral thinking enough, you can build on it and try to find the next innovative step. The other thing that I've embedded into this talk, and other speakers have mentioned, now I don't ski, but you get to travel everywhere, and that's a very exciting aspect of life. I can look forward to a bit of an overseas jaunt in August, maybe a bit of Italy action. When we're setting up the clinical trial in New Zealand, I said to Prathi, next year you set up a clinical trial, maybe you can run a little symposium just like today, and maybe you can invite me. And she says, yeah, so 12th of May, I'm popping over to New Zealand. But I wanted to just emphasise that what is very exciting is that you can have a split brain, and I think the advantage for us is that if you're good, you know what's possible in the laboratory and you know what's needed in the clinic, and you combine them together, and that's a very advantage of being a clinician-scientist. But I just want to end on one note, which I'm just a bit worried that there's a bit of a subtle subliminal message that might be percolating through, and I just wanted to be a bit controversial and combat a little bit. I want you to, if I wanted to just teach you, oh, just went all quiet. What's he going to say? I just wanted to say that our scientific, non-clinical colleagues are every bit as important as a partner to us. If I didn't have my senior scientists in my lab, this diagnostics therapeutics stuff will just stop overnight. They don't get paid as well as us. You've got to be passionate to stay in the scientific game, and I feel very sorry that that's the case, because they're every bit as smarter, and I would argue smarter than a lot of clinicians out there. So you've got to value them, and you're not better than them. And if you're in the lab, you go on the lab roster and you do it willingly. And if there's a scientific presentation and it's a colleague you've been working in the lab, you make it there. Don't put it as a second option. And I prize, and our family is very much the clinician scientist with the scientists, and in turn, they'll look after you well and you can go places. Thank you very much for your time.
thanks a lot, Stephen. And I think that it was a fabulous talk, but I think that final point about how we should have high-quality relationships with colleagues was very well meant, and excellent point. So we have a little time for one or two questions. And if you have questions, please use the microphone. Yep. So one here. Yep.
Thank you for your talk. You spoke a lot about treatment and a treatment focus for clinician scientists. And I was just wondering whether you think that clinician scientists also have a role in early detection, particularly something like preeclampsia.
Okay, I'd firstly like to just thank you very much for the question, because it really broke the awkwardness of no questions. Thank you. 200%. I think diagnostics and therapeutics is the role we can play in improving outcome. And there is incredible work in the space of diagnostics to better detect preeclampsia, and that was absolutely a whole part of that translational research.
Thanks, Ingrid.
Thanks, Stephen. That was as inspirational as I expected, so thank you for that. I really thought that last point was incredibly important, and whilst we're here talking to you about how great it is to be a clinician scientist, we can't go it alone. We have to do it with the scientists, who are often smarter than we are. And the question I want to ask you is a bit of a curly one, of course, and that is, how do you ensure that their careers get enough time in the sun, not just the big professor and the clinician, and how do you make sure they get enough accolades? How do you help them with their career promotion? Because I think that we are in an easier space.
I think that question, and I did curtail my talk a little bit, but another part of my strong passions is mentorship, both clinician scientists and scientists. It's up to the scientists to judge whether I'm good at it, but I plot their careers really carefully because they are a super vulnerable group. So I go through what's going to be their targets in terms of publications. I make sure that when I go to conferences and networking, they are the forefront of it. I definitely do not hog that senior authorship spot or the first authorship spot, because that's the wrong thing to do. And I don't give it to them. I put them on because that's where they should be. And you shouldn't start hogging the scientists, and in turn, they'll help you do good research. But I do sit down and plot their career very carefully, and other aspects. I make sure I mentor them how to write properly, how to present properly. But their career is every bit as important to me than actually translating something. And our group's grown and grown, and our problem is it's hard to move people along because we love everyone. It's a growing family. It's bigger than the Brady Bunch.
Look, with that, I think that's a great note on which to end the session, and thank you very much, Stephen. And look, I think some of the powerful themes from this session, which I've really enjoyed, and I hope you have too, it's really about of course, the importance of translation and data and evidence in medicine. I think we've heard a lot about non-linear career paths and how that's a good thing, not a threatening thing, and something to be embraced. I think we've heard from all of our speakers the great benefit of going away, but the importance also of learning and enriching and then coming back to Australia. And I've just enjoyed the diversity of, you've heard from 3 highly accomplished clinician scientists, but with very different career paths and experience, and I hope it's been as exciting for you as it has been for me. And with that, before you go to lunch, I want to hand to Aidan. Thanks.
So
So before we head out to lunch, I just want to say again that thanks very much to the 3 speakers we've had for an incredible look at the different variety of what a clinician scientist can do. We've heard from a neurosurgeon, a general practitioner, an obstetrician who will look at what a clinician scientist does in a very different way. Out in the lunch area, we have 6 research institutes from around Melbourne and 3 universities who also look at what a clinician scientist is in a very different way. And I'd encourage you to visit each of their stalls. We're also running some poster tours by a few of our speakers. If you've signed up to a poster tour, it would be great if you could meet your speaker at the registration desk at 1:20. We've changed the timing a little bit just so people have a chance to eat lunch first. So meet your speaker at 1:20 and then they'll take you on a tour of the different posters on display. If you're not part of a poster tour, you're definitely welcome to go around different institute stalls and have a look at their posters, talk to the representatives there and talk to the uni representatives as well. We'll have the 3 university stalls just kind of behind here if you walk around the corner, and the institute stalls over the other side where everyone was eating morning tea. So we'll see you back in here for the next talks at the end of lunch, and thanks very much.